people coming in. Hello, everyone. Good day to you. My name is Jake Morgan. I'll be the moderator for this session. I'm really excited to have you all here to talk about big data and health economic analyses in a few different populations and locations. Our schedule for today is you're going to hear from three speakers, myself, Jackie, and Eric, and then we will hear from our wonderful discussant and open it up for questions throughout. We're going to hold all questions to the end. And as you come up with them, feel free to chat them and I will read them aloud, or we can do it live as well. So to be respectful to everyone's time, we're going to go ahead and get started. I'm going to do this in the order on the program. So I think that means, yes, I am first up. So let's get started. Each presenter, we have three presenters, so we'll be going between 8 and 10 minutes. And that's that. Great. Share screen. All right. Feel free to just pop in if anything seems to be amiss. I'll start my stopwatch. So great. My name is Jake Morgan. I'm an assistant professor at Boston University. If you're interested in big data, substance use, things like that, feel free to follow me on Twitter at Dr. Jake R. Morgan. I'll be talking about variation in initiation, engagement, and retention on medications for opioid use disorder based on health insurance plan design. I would like to recognize some funding from the United States National Institute on Drug Abuse. So in the US, the opioid overdose is a crisis. The number of fatal overdoses has been increasing year over year. You can see from this graph of the 12-month periods in each month from the Centers for Disease Control and Prevention, that the rate of overdose deaths has roughly doubled between 2015 and the end of 2021. This got worse during COVID due to difficulties in accessing care and things like that. And for opioid use disorder, the key treatment is medication. That's what we'll be talking about today. There are several forms that are approved in the US and globally with some slight differences. But that has been shown to reduce overdose, decrease cravings, and improve quality of life overall. So also in the United States, however, insurance can pose a barrier as health insurance coverage is central to medication access specifically. So there's large variation in commercial plans. So that's what I'll be talking about today. These are plans that are provided in the United States to individuals through their employers or based on buying them from private plans. And these contain out-of-pocket expenses and deductibles, which I'll talk about in just a minute. There's limited evidence in the role of this cost variation in attaining medications for opioid use disorder specifically. There's been work in other diseases. As you can imagine, the severity of the disease and cost of treatment affects uptake, but this hasn't really been communicated here as of yet. So our aim was to evaluate the association of cost sharing on the initiation of retention and engagement to medications among individuals with commercial insurance in the United States. We used a large database called Optum Labs, which has administrative billing claims from medical and pharmacy settings. And it also critically is information on someone's insurance plan design. This can be hard to get here because a lot of these plans are different and kind of protected as company secrets. So we looked at individuals between October 2015 and 2019 who were enrolled in the data for at least 3 months and had full information on that cost sharing details. And we pre-specified this in a registered protocol on open science framework, which we're really trying to embrace in my lab to increase transparency with this kind of research. So we had 2 cost-sharing exposures. One was a deductible. So in the United States, a deductible is the amount that you have to pay before insurance will cover anything. And this is often hits before your copay is applicable. We bionizer this as high and low based on $1,000 from previous literature and also some tax concerns in the United States. Specifically, you can have a deductible for office visits and pharmacy. These two care methods are often kind of split apart. You'll have somebody managing your pharmacy benefits and somebody managing your medical benefits. There's also copays, which are fixed amounts that persist, whether or not you've met or after you've met your deductible. And these are small amounts for an office visit or a pharmacy. So you might have to pay $30 to go see a doctor or $5 for a drug. And that is set aside from any other cost sharing that you might have. Our outcomes were based on the National Committee of Quality Assurance metrics, where we looked at initiation, medication receipt within 14 days of diagnosis, engagement, the second dose being received within 34 days of the first, and retention, which is receiving medication consistently over 180 days. These are quality metrics that are used to rate hospitals and for other kind of purposes. And so we believe they're important to our stakeholders. We controlled for a bevy of other variables, their demographic, clinical, and calendar time, and used all this in a multivariable logistic regression where we predicted each quality outcome. So for our results, we identified 10,513 individuals. Most were male between the ages of 25 and 64 and lived in the metropolitan region. Overall, of those 10,513 that we identified as having a new opioid use diagnosis, 11% initiated medication treatment, 7% received that second prescription within 34 days, and 2% were retained over 180 days. Next, we looked at our logistic regression predicting initiation. And what we found was that only the medical deductible, so specifically having a high deductible over $1,000, was associated with a decrease in the odds of initiating treatment after diagnosis. I am not going to present engagement and retention results because there were no significant findings when it comes to cost sharing variables. These results are in the multivariable framework, so everything else is being controlled for in this example. So the limitations here were that we were only looking at commercially insured individuals who may have differential response to cost sharing than others, including publicly insured. So in the United States, there are some people who qualify for public insurance based on age or kind of medical conditions that they might have, and as well as income. And there may be different responses to cost sharing in that population. So overall, we found that only 11% initiated medications within 14 days and only 2% were retained at 6 months. This is something that we've seen before, so it's not unusual to see this, but it was definitely disheartening to see it in this kind of stark presentation. And we found that a high medical deductible was associated with the reduction in the odds of initiating medication treatment compared to a low deductible. So these results add medical deductible to a substantial list of barriers to medication initiation, includes stigma and accessibility providers, and a whole bevy of things. So it's already really hard to get a medication treatment in the US setting. You have to have oftentimes a doctor who has been specially trained to give it to you. You have to go to a special place and be on a list and do all these other things. And so, this is something else that hasn't been separately studied a lot that may pose a barrier. And we believe that future work should consider the influence of out-of-pocket costs for a whole other, this speaks to my point of all the other barriers have to be overcome. So oftentimes you'll have to go in for routine drug testing. You'll need medical and behavioral healthcare visits and monitoring. And there's often other high costs upstream that may spark either a diagnosis or the start of treatment, things like inpatient detoxification, that are extremely expensive. And so these other things upstream may also be affecting whether or not someone engages because they've already spent a bunch of money on whatever it is. Or besides the cost of the medication itself, there's all this other stuff going on. And I think that speaks to our finding of specifically the medical deductible rather than the pharmacy copay cost, for example, being really important here. And the lack of a clear signal of cost sharing among those who have already initiated suggests that barriers may change along the cascade. So I didn't present these results of engaged or retained because there were nothing significant or really interesting. But this suggests that maybe, there are different, after you've climbed over these barriers to get the drug the first time, maybe you face kind of different barriers to stay retained or to get engaged that we should look at. So our findings suggest that cost sharing may be a significant barrier to starting treatment, but more research is needed to understand the barriers to engaging and remaining retained in care. So again, please hold your questions till the end. And I believe next up, we have Dr. Allison.
Great. Can you, let me try to share my screen. All right, can you all see that?
It looks great.
Great, thank you. So my name is Jackie Ellison. I'm a postdoc at Brown University. Today I'll be presenting some early work on assessing geographic variation in the use of gender-affirming care for Medicaid enrollees in the US. So transgender and non-binary Americans disproportionately experience uninsurance and other cost-related barriers to care. This population is also more likely to report negative experiences with insurance and with healthcare providers. So from the 2015 US Transgender Survey, we know that 1 in 4 respondents experienced a problem with their insurance that was directly related to being transgender. Over half of people who sought coverage for transition-related surgery were denied coverage, and 1 in 4 who sought coverage for hormones were denied. So a major reason why trans people are vulnerable to cost and access issues is because many experience gender dysphoria. And gender dysphoria is a clinical diagnosis that describes the stress that people experience when there's a discordance between their gender identity and their assigned sex. So to treat dysphoria, many trans people seek out gender-affirming medical care, which is an individualized treatment that will differ according to each person's needs. Gender-affirming medical interventions include hormone replacement therapy and gender-affirming surgeries, including chest and genital reconstruction, facial reconstruction, hair removal, and voice therapy. So gender-affirming care is a medically necessary and effective treatment for gender dysphoria. However, there are major ambiguities and inconsistencies around insurance coverage for these services, which ultimately vary by payer, state, and provider. So many states in the US have explicit policies that categorically include or exclude coverage for gender-affirming services. And these policies are implemented by states to regulate both Medicaid and commercial insurance. So as Jake talked about a little already, but if you're not familiar with the structure of healthcare financing in the US, most working age people have health insurance coverage through their employer, and people over age 65 are eligible for the federally funded Medicare program. Low income working age people who don't have an employer that offers insurance are often covered by Medicaid, which is jointly funded through national and state governments. And because it's jointly funded, state governments often make decisions about what services are covered and what services are not covered. So the focus of our study is on people with Medicaid or low-income working age people. So I'll discuss Medicaid policies explicitly. As of 2020, gender-affirming hormone therapy was a covered benefit in 34 out of 50 states. And gender-affirming surgery is a covered benefit in only half of US states. And I want to note that these maps show the current landscape. So most protective policies were implemented in the past decade, with California being the first state to issue a protective policy in 2013. The first ban on gender-affirming care was passed in the state of Nebraska in 1990. So partly because of stigma, trans health is understudied. Current research is limited by the lack of studies following large populations over time. To address this, there's been a somewhat recent increase in research that leverages insurance claims data to look at health outcomes and service use among trans people. Most of this literature uses trans-specific diagnosis and procedure codes to identify trans enrollees. However, these methods may overlook gender minorities who don't have the trans-specific diagnosis or who haven't undergone a trans-specific medical procedure. And this will be important to identify trans people living in states with policies, like I just mentioned, that limit insurance coverage for gender-affirming care. So to address these gaps, the purpose of the study is to refine and apply an algorithm to identify transgender individuals in Medicaid data and evaluate state variation in use of gender-affirming care. So the study population includes transgender adults ages 18 to 64. We use 10 years of inpatient, outpatient, and pharmacy data from 14 states. Half of these states implemented regulations or guidance explicitly stating that their Medicaid program covers gender-affirming care. 3 states implemented policies that explicitly exclude gender-affirming care, and 4 states have released no formal policy in gender-affirming care. So given the years of data that we have, the only state that would be affected by a trans-specific policy is Georgia, which explicitly excluded coverage for gender-affirming services in 1993. So while claims data don't contain information on gender identity, they do contain diagnosis and procedure codes that indicate whether an individual has a diagnosis of gender dysphoria or a gender-affirming surgery. So the problem with using these codes, as I mentioned, is they don't capture trans people who don't have dysphoria or who don't want the gender identity code in their medical record or who haven't had a gender-affirming surgery. So identifying trans people that don't fall into any of these categories is especially important for people in states that ban coverage for affirming care. So to address this, we expand on existing algorithms to identify low-income gender minorities using 4 distinct categories. Category A and B, as I mentioned, are the most used in claims research. Category A is anyone with a diagnosis code of gender dysphoria. Category B is anyone with a procedure code for a conclusive trans surgical procedure. Category C is anyone with a suggestive trans procedure code and an endocrine disorder code. To clarify, endocrine disorder is commonly used for trans patients instead of a gender identity disorder. So if a trans patient doesn't have gender dysphoria, or if they don't, again, want to have the gender identity disorder code in their medical record. Category D is endocrine disorder and a prescription for a qualifying sex hormone. So in this situation, endocrine disorder can be used by providers to get around potential billing issues if hormone replacement therapy is not a covered benefit in that state. And again, to clarify the difference between conclusive and suggestive trans procedure, a conclusive trans procedure code, an example would be operation for sex transformation. An example of a suggestive trans procedure code would be amputation of penis for someone who has no history of penile cancer. So here we have the total number of trans individuals identified across states, along with a proportion that fell into each algorithm category. Categories A through D are not mutually exclusive, so someone could have been identified in more than one way. Across states, most people were identified using the endocrine disorder and suggestive surgical procedure or the endocrine disorder and hormone prescription, although there is some interesting state variation. So we see that Georgia was the only state with a gender-affirming care ban, and relative to other states, very few had a diagnosis of gender dysphoria or a conclusive trans-specific procedure. And most trans folks in Georgia were identified with the endocrine disorder and diagnosis, with an endocrine disorder diagnosis and hormone prescription. So we're in the process of obtaining national updated data. Once we get data that captures all states, we'll be able to use quasi-experimental methods to evaluate the effect of specific gender-affirming care policies on care engagement among trans people. Specifically, we're interested in preventive service use and diagnosis and treatment engagement for chronic conditions. The idea here is we think trans people living in states with gender-affirming care protections will have better health outcomes and be more engaged in care across their health conditions. Also, we're working on refining the algorithm to distinguish between transmasculine and transfeminine enrollees so we can look at patterns and service use for each of these populations that have different needs. As I mentioned, this work is in its early stages. We're still waiting on updated data, but just to get an idea of what the trans population looks like, I pulled a matched sample of cis people, and we can see that trans people are 5 times as likely to have a cardiovascular disease, almost 3 times as likely to have HIV, and almost 8 times as likely to have a psychiatric disease. They're also twice as likely to have a history of cancer or diabetes. So there are some pretty disturbing and substantial disparities here. It'll be important to see how care engagement varies geographically based on state-level gender-affirming care policies. So thank you very much. I'd like to acknowledge my co-authors, and I look forward to hearing your thoughts.
Thank you, Jackie. Eric, I believe you're up.
Okay. Okay, can you see my slides?
Yes.
Okay. Okay, thank you, Dr. Morgan, and hello, everyone. Today, I'd like to present my preliminary results on the analysis of hospice palliative care utilization in Taiwan.
Eric, I'm sorry to interrupt you. We can see your presenter view. So if you want to.
Oh, sorry. Oh, really?
That's okay.
Oh, really? Sorry. How can I do that? Hmm. How about this one?
That's good. So that's perfect.
Okay, okay. Yeah, I'm okay. First of all, I have nothing to declare. As you know, the population on Earth is getting older and older, and more people dying from serious chronic disease instead of acute disease. People suffer from multi-organ failure toward the end of their life. Aggressive treatment might be not the best choice for this situation. Okay, so the idea of hospice palliative care was introduced by Dr. Sanders in 1967 and spread to Asia 20 years later. Also, there are many studies on the utilization and the facilitator of hospice palliative care, but most of them were conducted in Western country. Relevant discussion in Eastern country, Israel. Before my start, I'd like to give you a brief introduction of Taiwan. Taiwan lies on the west edge of the Pacific. There are 23 million people living in this 36,000 square kilometers island, and more than 99% of Taiwanese people are covered by national health insurance since 1995, which is a single-payer compulsory social insurance plan, and more than 90% healthcare organization contract with NHI. Sorry. The life expectancy in Taiwan is longer than 80, but Taiwanese people only spend less than 10% of GDP on health consumption. Okay, next, I'd like to show you the history of hospice palliative care development in Taiwan. The idea of hospice palliative care was introduced into Taiwan by Dr. Zhong in 1983. And 7 years later, the first hospice ward was opened. And 5 years later, in 1995, we start national health insurance, and the central government established a hospice palliative care promotion task force. Okay. In 1996, the NHI started a home-based hospice demonstration program, and in 2000, the hospital-based hospice demonstration program was started. And all of these programs only cover cancer patient, amyotrophic lateral sclerosis, and AIDS patient. And in 2000, the same year, the Hospice Palliative Care Act was passed, and Taiwan became the first country in Asia to legislate to protect natural deaths. And in 2009, NHI expanded its payment coverage from 3 diseases to all terminal major organ failure patients. And in 2017, the Patient Right to Autonomy Act was passed. Taiwan also became the first country in Asia to allow patients to set up the advanced directive. Okay, in past decades, the attitude toward hospice palliative care in Taiwan society has been changed a lot. Therefore, my study takes Taiwan as an example to fill following objectives. Okay, this is a retrospective claims data analysis. People who died between 2001 to 2017 were our study population. We also collect medical utilization information for 12 months before their death. Taiwan National Health Insurance Claims data, death registry, and the cancer registry was used as our data sources. This is our variables. Our dependent variable include hospice palliative care use and the duration of hospice palliative care use before their death. Age, economic status, and the residential area was our main variable. We also collect information on demographic variable, including gender, marital status, health status, and the cause of death. A total of 2,835,000 people died between our study period. Most people died at the age between 95 to 85. 99% living in urban area and 5% were low-income people. Regarding the demographic information, the gender ratio was 6 to 4. 11 was single, others were married, divorced, and widow, and 50% had catastrophic illness, and 30% had cancer. As you see, the hospice palliative care utilization rate was increased over time, especially after 2010. The utilization has increased significantly. However, the duration of hospice palliative care was increased from 2000 to 2009 and decreased after 2010. Until 2015, the duration started to slightly increase. In this figure, you can see the 40 to 65 years old group was most likely to use hospice palliative care, followed by 65 to 85 years old group. And you also found the utilization rate of 6 to 12 years old group was dramatically increased in recent years. We also found non-low-income population were prone to use hospice palliative care, and female was prone to use hospice palliative care too. And then we found urban dwellers were more likely to use hospice palliative care, and the people who had catastrophic illness and cancer were prone to use hospice palliative care. And we also found married and divorced people like to use HPC as well. Okay, in our statistic, we found the duration of hospice palliative care was not varied among demographic characteristics. So I won't show you any result here. Finally, let us focus on the effect of urban and rural difference after payment coverage expansion. The result reveals the urban-rural differences was enlarged after payment expansion, especially in middle-age group. Now we can see the effect on the poor non-poor differences, and we also found the poor non-poor differences was enlarged as well. Okay. I have some issue to share with you. First, why did the chain of hospice palliative care use suddenly increase after 2010? Except for the payment coverage expansion, from the other point of view, I think perhaps the need of hospice palliative care use has been exist in Taiwan society for a long time. Okay. The next issue is why children and elderly people were less affected after policy change. I think for children, it is easy to understand. Parents always want to prolong their life as possible as they can. But for elder people, the phenomenon might be explained from the social cultural perspectives. Chinese parental respect is a core in Taiwan society. If a child decides to use palliative care for his parent, then he or she might took a lot of pressure from from he or her elder relatives and might be considered not a good son or good daughter? It's a big question. Finally, why people live in urban area or had better income status, had better hospice palliative care utilization rate compared to their peer of the same age? In my opinion, except for social cultural factor I mentioned above, understanding toward hospice palliative care would be the reason. Some people in Taiwan usually conflate hospice palliative care with either euthanasia or assisted suicide. The transmission of correct information is slower among disadvantaged groups. So it could be used to explain why the gap between advantaged group and the disadvantaged group has enlarged. So in my study, I have some limitation, especially I don't have enough information on correct information, such as attitude, accessibility, and social support or patient-provider relationship. So this is our limitation. So in summary, we found that the utilization was increased in Taiwan society over time. However, the growth rate among various social demographic group was varied. Advantage group had a higher growth rate. So understanding the difference might be the next issue to my study. Thank you.
Thank you, Eric, and thanks to all the speakers for keeping us on time. Eric, if you want to unshare your screen, I think now you can. Yeah, thank you.
Okay, here, stop. No. Yeah, here.
Perfect, thank you. And now we can hear from our discussant.
Can you guys see it?
We can.
All right. Hi, everyone. I'm Jani Jawadane from University of Georgia. I'm glad to discuss the papers. I know there were 4 papers on the schedule, but unfortunately, one of our presenters could not attend, so I'll skip on that. So I'll go on the order that you all presented here in discussing the papers. First by Jake, I think he was looking at estimating the association between insurance plan design and initiation, engagement, and retention to medication treatment for opioid use disorder, especially looking at the United States population here. And the data they're using are coming from Optum Lab data warehouse. It's a large national commercial insurance claims database, and they have data from 2015 to 2019 for all inpatient, outpatient, and pharmacy claims data. I think they started with about 125 million enrollees, pretty large database there. And they're mostly focusing on medications, 3 specific medications used for opioid use disorder commonly here in the US, which is buprenorphine, naltrexone, and methadone. So out of the 125 million claims enrollees that they had in their data, they found a little, about close to about 11,000 individuals identified with opioid use disorder. And of those, about 11% were initiating the medications for opioid use disorder treatment. And 7% were engaged in treatment and 2% were actually retaining at the 6 months time period. So they were adhering to use of medications at 6 months at that time. And primary finding that they're finding is that the high medical deductible, people that have higher medical deductible were associated with low odds of initiating these medications for treatment. In terms of, I thought this was a great work. It's very important to understand the insurance plan design and how that is impacting decisions, especially decisions with regard to healthcare utilization. So I definitely enjoy reading your paper. Thank you, Jake, for sending it to me in advance. I would like, I think, to more a little bit more information about the data source, right? The Optum Lab data, is it a sort of representative sample of the US, or are all states included, or, is it more specific or higher weight given to, like, say, Northeast or Southern states, etc.? I'm not sure whether you observe locations or the states in your data. So that's something, maybe if you do not, that may be something you can put it in the limitation section, saying that you do not observe such data, right? Another question I had was about income levels. I don't know whether, again, given its claims data, whether you observe, because other thing came from also, you had very large data set, 125 million. Enrollees, only very small portion that you found with OUD, right? So that's another thing I think maybe you can discuss, is that the reasoning behind it, right? Because it is a commercial insurance, possibly is why, right? Mostly the people we are seeing in commercial insurance are the people work-sponsored who have work-sponsored health insurance care, right? So maybe that population, we know, especially like Medicaid population, tend to have a larger proportion of Medicaid population with the OUD diagnosis in the US generally. I did like a rough back of the envelope calculation in terms of general US population. It's only 0.6% population in the US identified with OUD, right? So it's sort of like, I think providing discussion to the reader would be helpful in comparing to other populations, such as Medicare and Medicaid populations, and also like commercial insurance in general kind of thing, right? Whether this number is that because the 10,000, about 11,000 people that you identified with OUD come to about 0.008% kind of thing. So it's sort of giving a little bit background would be helpful for the reader. And also I think initiation definition of 14 days. Again, I possibly, you followed the quality criteria that you have, maybe give a little bit more discussion onto that, why specifically you've picked 14 days. And also I was wondering whether you observe anything with regard to counseling, in terms of addiction counseling. I'm not sure whether the payments are made through claims for counseling, etc., or not, but maybe if not, even at least providing a discussion, because sometimes OUD patients receive counseling along with MOUD, right? Along with the medication use, so for treatment. So maybe just providing a discussion. If you have data for counseling, I would love to see what the data looks like for counseling, or whether there's coverage for counseling, and whether people are choosing to get counseling in, what proportion of people might be going to counseling instead of starting medications for opioid use disorder. So that kind of background would also be very helpful. Other thing also, I'm wondering, given the 14 days decision, whether you did any other kind of looking around in the data, were there higher proportion or lower proportion or none, basically starting late initiation of medications for OUD, right? So just 14 days is 2 weeks. Are people within the 30-day area? Some people are late to get on to the medications for treatment, right? So if you can look, it can also serve as maybe a sensitivity analysis, sort of like, are there people who are starting late on the medications, right? So maybe looking at those again, maybe a good idea. Another question I had was, using the $1,000 deductible mark. So you had a sort of a dummy variable, right? 10, looking at it, reasoning, coming up with that. Again, maybe it's easier in the data, but maybe did you look at other possible variation in like very high deductible, middle level of deductible, and lower? So maybe like over 1,000, maybe 500 to 1,000, and less than 500, something like that. Do you see a variation in that? I don't know whether, given your smaller sample, whether the sample will become very small as you are changing the variation. But again, I thought that could be something you can look into and maybe serve as a sensitivity analysis as well. Other thing I was also interested in finding out is, like, again, plan type, like also what type of plan, because you have plan characteristics such as the copay, deductible, etc. Do you I'm assuming, do you know whether they're on like HMO or PPO or high deductible health plan, et cetera, right? So if you can provide data on at least even descriptives, like how many percentage of population with OUD are falling into these different types of health plans that we have in the US. Obviously, you're going into more the second level of detail in terms of looking at the plan characteristics. But definitely plan characteristics vary depending on the type of plan people have, right? So maybe looking into that also, maybe I'm wondering like, certain population attracted to a certain type of health plan compared to other plans, et cetera. So I was wondering if you can, I mean, maybe these are some ideas to look into for future research, for future papers, right? Wondering whether other specific health plan or characteristics are more appealing to, OUD patients or not, kind of thing. So maybe that's something to look into. So I think that's all overall. Enjoy reading the paper. Thank you so much. And I'm moving on to next. I think the Jackie's paper. She was looking at geographic variation in the use of gender-affirming care among the Medicaid enrollees. Again, the goal of the project was to identify transgender Medicaid enrollees and evaluate state variation or state policy variation and how that is affecting the utilization of gender-affirming care. So they're basically using Medicaid claims data. Again, they have inpatient, outpatient, and pharmacy claims from 2002 to 2012 for 14 states, and they are mostly focusing on adult population that are identified as gender minority adults. And their primary finding is that variations in state policy they do find there is variations in state policy in terms of providing and covering gender-affirming care in the U.S. Again, I know I thought this is a very important study. We are seeing very few studies on this. I think this is a very up and coming area of study and very important study to look at. We all as healthcare professionals need to know more about these populations. So in terms of also, would like to see a little bit more background on the literature. Obviously, I guess I didn't receive a paper. Maybe you have that on the paper, right? So I had to do my discussion based on the slides. So maybe given the time limitation, you don't have that on the slides, their coverage. So I was also again wondering whether coverage, this is a very important population, Medicaid population, but I was also wondering if you can provide detail about comparing to other types of populations, such as the privately insured population or the Medicare population. How does the gender affirming care works in those other different types of populations or insurance coverage that we have in the US, right? And also, I think the first map that you had, sort of when I saw the first map that you had on the slides, kind of dawned on me, it's sort of, I felt like almost similar to the Medicaid expansion versus non-expansion state. So this might be again for a possible future project. Once you get, I know you have data until 2012 right now, and you sort of have right now is a descriptive study, but I think once you get up to 2017 data, maybe looking at also how does the gender affirming care works in Medicaid expansion versus non-expansion states, right? There may be a possible policy paper there. That's so how, whether coverage changes or it stays the same, because maybe there's not much about gender expansion, like a closed is not necessarily included in Medicaid expansion, right? But I was wondering whether more people entering into the coverage because of increased access to health insurance, et cetera. So that's something to do. And in terms of your data, you said Georgia is the only one that has, I think, that is banning gender affirming care according to the data, the time period that you're looking at. I also wonder, and looking at this, I also saw that Louisiana has similar outcomes in terms of your ABCD diagnoses that you have are quite similar to Georgia. The interesting was what Georgia is banning gender affirming care in '93, but Louisiana does not have a specific policy. That means they're sort of neutral. They're not either banning or protecting gender affirming care. But I was wondering, so that also could be maybe sort of, I felt like you have a treatment control kind of a group there, if you can look into those two states, given your current data that you can do, right? So instead of waiting for the new data to come, this is something you can look at what was going on in Louisiana, maybe, dig deeper into that, finding out where they didn't have a policy, what was going on, right, compared to Georgia kind of thing. So that's something to look into. I think that's all I have for your paper. And I think so. Next is I move on to Eric's paper now. So Eric's paper, not sure why this is coming. Do you guys also see the top? I can't get rid of that for some reason. I don't know why. Anyway, Eric's paper is looking at effects of hospice palliative care. So they're basically exploring the trend and preference of hospice palliative care utilization among various demographic groups in Taiwan. So they're using data from Taiwan National Health Insurance claims data, death registry, as well as cancer registry. They have patient information from people who died between 2001 and 2017. But they do actually get claims data 1 year prior to people's death. So they have data from 2000 on to 2017, basically. They are looking at their healthcare utilization 1 year prior to their death. So their primary health outcomes is basically hospice palliative care utilization entered as a dummy variable, and also they're looking at duration of this utilization in terms of measuring the duration in number of months. So they're basically, in their data, they have close to about 3 million people who have died during this time period. And out of that, about 424,000 people are receiving hospice palliative care. And they do see, in terms of the over time, hospice palliative care utilization has increased from about 3.3 to 23.9%. That's a pretty large increase given about 16-year time period, right, I think. And the main finding is that they're finding individuals that have higher income levels and also living in urban areas, and people who may be the age 40 to 65 and diagnosed with cancer are experiencing higher levels of utilization of hospice palliative care compared to their counterparts. This again I really enjoyed looking at this, and this I think is an interesting project. I know the paper is currently as a descriptive paper. Again, I think the ideas or comments I have are more of for possible future projects. I thought this is very informative, looking at how the hospice palliative care has changed in Taiwan over time. So that is very informative. And also, we saw in the trends that you saw after about 2009-10, you're seeing a huge increase or uptake of the hospice palliative care utilization. And again, that I think is maybe a future paper that you have is looking at the policies that came in, it seems like this NHI expanding the payment coverage, especially for the organ failure patients. That may be a reason behind. We don't know for sure, but that's something for a policy paper, right? So you actually have data for pre and post, and I think maybe you can also find a pretty good control group as well. So you can do a easy difference in differences analysis, and again, this will be a straightforward two-way fixed effects difference analysis, given that only one time policy change in 2009, but you obviously controlling for other factors. Maybe that is something to look into in the future, like, is this actually the policy that resulted in this, or was something else going on in terms of policy aspects, or in terms of other factors, socio-demographic factors in Taiwan, or even political factors, anything, in the environmental factors that's taking place at the time. So I think that would be also a bigger contribution. See whether this policy, then you can really for sure say right now we can only suspect, given the descriptive nature of the paper, that this might be the reason. But for surely you can say if you do a little bit more rigorous analysis of it. So with that, I think I'm going to wrap up. And with all papers I enjoyed, and also if you have questions, I'm happy to talk with each of you after the conference for, in terms of looking at the future projects, etc. I'm happy to, if you have questions, feel free to reach out to me via email. I'm happy to discuss on this about if you have questions. All right, I'll wrap up there.
Thank you, Jayami. That was very helpful. And I know my paper is kind of in the review process, revise and resubmit. And so these comments are actually extremely helpful to think about how to reframe some of this. So I appreciate that. So we have about 9 minutes left. So I thought that each of us would take 3 minutes Jayami gave us a very good framework of questions. So people could choose to respond to some of the questions she posed. And then there are a couple of questions in the chat too that I will highlight during that kind of 3 minutes. So let's go in backwards order. So Eric, I don't know if you want to have any concluding remarks or any response to what we just heard. And then there was a question in the chat for you about your experience in getting kind of this large database in Taiwan when it comes to the quality of clinical coding and like how hard it was. So if you want to talk about that.
Yeah, thank you. Thank you for your comments. Yes, in my study, I try to we try to explore the facilitated about hospice palliative care. So we use claims data to depict our data. Sorry, we try to depict our data firstly, so the users can see our preliminary results. About data quality, coding quality, I think Taiwan is not a big issue because it's relevant to reimbursement. So reimbursement is very important to hospitals. So they will make sure their data and their coding is correct, so they can get reimbursed. Okay.
Great. I also had one question for you, which was, we saw that kind of massive increase in uptake in palliative care. At the same time, we saw like a decrease in duration. Is that just because do you think you're capturing kind of a different set of people?
Yeah. Mm-hmm. I think I think the idea of palliative care in Taiwan is not mature. So people want to their patient or maybe their relative or their parents die more comfortable. So they choose to do palliative care in their last months. So I think we have a lot of work to do to promote that people get the right understanding about hospice palliative care.
Excellent.
This is my guest.
Yeah, thank you. Jackie, do you want to speak? And then there was also a question in the chat for you and I about how we standardize claim records kind of across states or coding schemes.
Sure. Yeah. First off, thank you so much for that feedback. I really appreciate it, and I apologize for not getting you a full paper. But I think I have. You gave me a lot to think about. I'm glad you pointed out the fact that we saw similar rates of trans categories in Louisiana as we did in Georgia. I think that's a really important point, and I think it might have to do with just like stigmatization of being trans in the South. And I think that will be very important to tease out, and the relationship between like stigma and these social policies is really interesting too. So that is something that I want to look at more. And just to speak to the comment or the question that we got from the audience. So I only looked at one payer, which is Medicaid, but you're right that like state Medicaid programs vary very like so substantially across states. And this is sort of the point of my study, is that we do expect that different providers are sort of providing different care and things might be coded differently. So if someone in Georgia if a provider in Georgia was serving a trans patient and they wanted to provide hormone replacement therapy, they might code an endocrine NOS disorder instead of a gender dysphoria disorder. So that is, I think that's the variation that we're looking at, is these between state differences in practices, coding practices. So thank you so much.
Great. Thank you, Jackie. And I had one question for you was, I think this is a great to try to identify people in a better way in claims data. And so I know that your A through D were overlapping, but do you have a kind of an idea of like the quantity of people you added? Was it like double? And then do you know if those people were way different than what were in kind of categories A and B?
Yeah, so we didn't look at like different characteristics of people in the different categories, but there is like, we did permutations and I wish I had presented on those. That was sort of an afterthought, but yeah, so there were people, I'm trying to remember. I can like send you numbers or talk to you about it later, but there was a lot of overlap. And I think we like almost doubled with categories C and D. So, but I'll have to double check.
Yeah, no, I was just looking for a general feeling. So that's really cool. Then,
yeah.
Right?
Yeah.
Thank you. Cool. And then I'll kind of wrap up. Thanks everyone for coming. A couple of responses for mine is this, how representative the sample has been something I've been thinking about with trying to frame. As was pointed out, the kind of prevalence we're finding is a lot less than normal, but I think that's because we're not actually looking at prevalence of OUD. We're trying to narrow it in specifically on people who have like newly diagnosed in a given year. And so that's part of it. And the reason that we're looking for kind of that new diagnosis is because the quality metrics are really focused in on what do you do when you get that first diagnosis, right? And how do you respond to that? But that, so that's kind of what we're thinking of there. And then also we had a kind of a strict data limitation. Getting that cost sharing data was actually kind of hard and very messy. Number one, this data provider was kind of one of the only ones that had it, but then also merging it in dropped a lot of people. So not very many, only a subsample of people had kind of full information, were steadily enrolled on a plan for 12 months or 3 months, I guess was my only requirement. So yeah, that was something that we were kind of struggling with. And then I also do think this is kind of response to two different questions. There's a lot that could be done with potentially like state fixed effects. I don't know if I have enough kind of sample and some of these regressions to be able to tease out like all 50, but I know that we've kind of controlled for broader regions before and found useful information that way. So I wonder if that could be a framing for this as well, to try to think about that. But anyway, this was super helpful. And, all of our slides are available online. And like, me, at least I put my email on there. So I would love to hear from anyone if you want to ask follow-ups or questions or anything else post-conference. I'm happy to engage with that. But yeah, thank you to all the speakers and our discussants. I think we had a really kind of fulfilling session this morning / this evening. And thanks to all our audience members as well. With that, I will wrap up.